Kia ora koutou and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. I'm Dr. Louise Kugler, a specialist GP, and I welcome Lucy O'Hagan to discuss managing uncertainty in the consultation. Dr. Lucy O'Hagan is a GP, medical educator, writer and mentor based at Oratoa, Cannons Creek in Porirua, after 20 years as a rural GP in Wanaka. She has been a medical educator with the Royal New Zealand College of General Practitioner, supporting struggling registrars and international graduates, and providing professional development to teachers. Lucy has written a column for New Zealand Doctor magazine for nearly a decade, and in 2024 recorded Waiting for COVID, a series of stories from the pandemic. Massey University Press will publish her book, Everything But the Medicine, later this year. Kia ora, Lucy, and welcome to the podcast.
Kia ora, Louise. Lovely to be here. Thank you for having me.
It's so nice to have you with us today. So, all consultations entail some sort of uncertainty, and handling uncertainty is a source of stress to clinicians who are taught the black and white of science. Patients also need to understand that uncertainty is normal in healthcare. Good communication is crucial, and complaints often occur when a clinician is not a skilled communicator. Clear communication is part of the art of practicing medicine. So, Lucy, let's talk about uncertainty. How do medical professionals experience uncertainty in consultations, and why is it important to acknowledge it?
Right, well, that's a great opening question. And before I start, I just wanted to say that my positioning in here is as a general practitioner. And my experience is in what I have always called general practice, but I'm trying to call primary health care. And I'm aware that in the audience, there are other practitioners who are also prescribers. But to be a prescriber, you have to make a diagnosis. And I also want to acknowledge the College of GPs who have supported this work over the last few years. So there's different types of uncertainty. Today, I'm going to focus on diagnostic uncertainty. So that's when we don't know what's wrong with the person. Sometimes we don't know because there's some limitation to the biomedical model that doesn't actually have a description for these symptoms. Sometimes we have a diagnosis, but we've got a bit of uncertainty what to do. And in the last decade, Health Pathways has really helped us with that. But sometimes there's uncertainty because there's limits to the evidence of what to do. There's also often uncertainty about who can help. And health systems and referral processes are incredibly complex, and that can create a lot of uncertainty. Who can help me with this problem? And of course, access to secondary care or any specialised services become more difficult, and that creates more uncertainty because you've got to work out what to do if no one else is going to help you. So it's tough a world out there in primary health care, but today we are going to focus on diagnostic uncertainty.
So, Lucy, what are some of the misconceptions about not knowing in healthcare, and how do they impact decision-making?
Well, I think we're talking about not knowing what's wrong with someone, and that is way more common in primary healthcare than secondary care. And the evidence from general practice is that we can only make a diagnosis about 40% of the time, and that's partly because we're seeing illness early in its presentation before there's the diagnostic criteria. Sometimes we're seeing things that are just going to get better, that are never going to reach a diagnostic criteria. We have a lack of investigations that give us immediate information, like a CRP and a full blood count. Some symptoms are never going to meet the criteria for a medical diagnosis. The problem with not knowing is that, particularly in medicine, knowing is the gold standard. So we are primed to know what is wrong and what to do. And so when we don't know, we get uncomfortable, and that can make people really anxious. And the problem with diagnostic uncertainty is it doesn't work very well if you're anxious, because you need your full cognition to work out what you're going to do. Sometimes when people feel anxious, they over-investigate or over-refer. Occasionally you get people who are anxious about not knowing, and they are actually go a little bit overconfident and latch onto one diagnosis. So you might have someone who says, oh, this person's got a urinary tract infection. It's a little bit odd, there's something odd about it. but they just latch on to the sort of simplest thing, and then they don't go through the process that would actually give them a slightly different set of differentials. So it's about being confidently certain. You don't want to be too confident, you want to be curious. And so I think the other problem is that when you're anxious, you tend to overemphasize what you don't know instead of asking yourself what you do know. And mostly we do know something about most things, or we have the ability to find out. So I think the other thing is to be really specific about what you don't know. For example, you might have someone who says, I don't know anything about liver function tests and how to interpret them. But when you actually hone it down, they have a very specific question. They actually do know about liver function tests. What they don't know is whether this level of transaminases is consistent with fatty liver or whether that's too high for fatty liver. So, which actually in that scenario, you probably go back to your differentials. But so being very specific about the part that you don't know or you're unsure about.
So when there is uncertainty, Lucy, what strategies can clinicians use when encountering a condition or symptom that they are unfamiliar with?
What I tend to say to registrars is always too soon to panic. And I think the other thing is that you don't want to tell the patient too early that you don't know. And I think the reason for that is the patient can lose confidence in you. And in order for you to get to the end of the consultation, for you to be able to explain the diagnostic uncertainty, you need them to trust you. I think you can hold on to your feeling of not knowing, and you don't have to expose that to the patient too early until you've made a sort of process for what you're going to do. There's a very specific situation where a patient might come with a diagnosis that we've never heard of. So, the parent might come in and say, my child's got blue-blueopathy, and blue-blueopathy doesn't actually exist, but it doesn't matter. If they said that, I would go, you wouldn't say to the parent, I've never heard of blue-blueopathy, I can't help you in any way. You wouldn't actually do that because you know that you have the ability to find out about blue-blueopathy and you have the skills to work out what a whānau might need from a primary healthcare team. So there's a little bit in that situation of masterful bluffing, what I call masterful bluffing. So you may know nothing about blue-blueopathy, but you can ask the patient how it affects them. What sort of treatment has your child had for blue-blueopathy? What does the specialist say about it? How does it impact your whānau? When you've had a GP before, how did they help you with it? What support did they give you and what was useful to you? And then you might disclose at the end that, I really need to read through all the referral letters and make sure that I'm really up to speed with blue-blueopathy and work out how I can support you. So in a sense, you can conduct that whole consultation without saying, I don't know anything about it, because knowing something about it isn't necessarily the point. But the more common thing is that you've got a symptom that you don't know about. So a skin rash that you've never seen before, or some really odd symptoms. So you might use an example like you have a man who comes in who says he's got numb patches. So he's got numb patches sometimes on his arm, sometimes on his leg, sometimes on his scalp, and they move around. And, we're immediately going, that is weird. We can barely even think about what that might be. And we're in a bit of a panic because we're going, what am I going to do here? So I remember when I was studying the Masters of General Practice at Otago, I remember Wayne Cunningham saying to me, this sort of changed my life really, in uncertainty we make a plan. And I think that's the really important message, is that it's okay to not know. The patient doesn't mind if you don't know, but they do mind if you don't have a plan. And so you have to work out some strategy for what you're going to do and how you're going to organise things. And so to make a plan, you always need more information. So you've got to do something sensible, like take a sensible history, ask some questions, do a sensible examination. And what happens when you do that, when you're a bit of a panic about the numb patches moving, is it engages your cognition and it gives you time to think and to make a plan. And also, if you're going to refer or you're going to ask someone else, you need to have some information to give them. So You start with something sensible, which is taking a history and doing an examination.
So, Lucy, you've mentioned taking a history. I wonder if a structured history helps us manage uncertainty in real time and how that contributes to our diagnostic reasoning and answering the question, is this serious? Do I need to panic?
What's wrong with the patient is one question, and are they sick is another question. And it's really important to answer the question, is this patient in front of me really sick? Because you've got to go, does it matter today, or have I got time to work this out? And one of the things in general practice is that people often don't look that sick. And that's tricky because sometimes we actually forget to do our diagnostic process because they don't look like there's too much wrong with them. But of course, sometimes we're seeing people very early. So we might see someone with a pain in the face today who tomorrow has shingles. And I think the other thing about the urgency is you can ask, is it getting worse? Has it got worse in the last 24 hours? Has it got worse in the last week? So if the man with numb patches is suddenly escalating, then that sort of changes the urgency with which I'm going about my plan. So diagnostic reasoning is absolutely critical to being able to work your way through uncertainty. And it's not actually that well taught. We even have registrars who, because the patients aren't sick, they sort of forget to do it. And the problem is that you get away with that. You get away with just giving an easy answer like this is a urine infection, this is a urine infection, this is a urine infection, without doing differentials until one day you don't because you've got primary genital herpes and you never thought of it. And we only do that once in our life. So you get away with it in primary care of not doing good diagnostic reasoning. And we have to be really wary of that. And I'm super fastidious about it with our GP trainees because I was a rural doctor for so long. If you make a diagnostic error, then that person is going to be back on your phone at 3 a.m. in a really unwell state, and that's the last thing you want. So you're always thinking, what could go wrong here? But in terms of uncertainty, I think what you've got to do is you've got to try and bring up a differential diagnosis at the start. And you need to know in those list of differentials, what are the worst things that you want to exclude? And if the person's really sick, what do you need to exclude today? And then you do a history and examination which is focused on working out which differential is most likely. And sometimes in the process of the history and examination, you get a new symptom, so then you've got another set of differentials. So you started off with someone with hemoptysis, and then you ended up with someone who also has a hoarse voice. So you've got another set of differentials to bring in. But the other thing about differential diagnosis and uncertainty is, and I think GP registrars can find this quite tricky, is to name which is the most common differential in primary health care. Because at the end of the consultation, when you're trying to explain and reassure, you won't be able to do it very well unless you can weight the probabilities. Unless you can say the most likely thing is this, but if you've just focused on the worst things, then you won't be able to do that. It's really good to give yourself a diagnostic pause. So that might be getting the person to come back. It might be, send them out for a urine sample so you've got time to think. You might wash your hands. You might tell them you're going to look it up and call them back. And the other thing about differentials is you can't safety net without differentials. You can only do a very general safety net, which is you've got one red eye. Oh, well, I think you've probably got hay fever. Come back in a week if you know better. Well, you only do that if you haven't brought up all the differentials of the really bad things, in which case you're saying your safety net is going to be way more specific and the timing of it is going to be way better. So the problem with the man who's got numbness moving around his body is really hard to come up with any differentials. I mean, you might go, oh, what's he got? Maybe he's got MS. I don't know. I've never heard of that in MS. And then you start to go, well, maybe there's something I don't know. And that's when you think about referral, because the things we don't know are a little bit dangerous. Or it might be that this person with numbness is never going to reach the traditional criteria for any medical diagnosis. And that's a whole other topic. One of the problems in uncertainty is it might be that we're never going to get a diagnosis for that particular person.
So you mentioned health pathways, but what role does using online resources help us when we're managing uncertainty?
Interestingly, I think health pathways often starts with a diagnosis rather than a symptom. Sometimes it's a symptom, and that's a bit easier for us in diagnostic uncertainty. There's some great resources around though. So DoomNet, they used to have a section called Browse where you could look at all the blistering skin conditions or all the bruising skin conditions. And now they have this thing called Skin Checker where you put in the body part and characteristics of it and it gives you a differential. Interestingly enough, the other day I just went on my phone and Googled, with the support of AI, the differential diagnosis of one red eye and the differential diagnosis of a lump in the neck. And honestly, it was a pretty good list. Like, I was kind of a bit gobsmacked. And I think what's actually going to happen, I don't know if you were in 2019 at the GP conference, the chief medical officer from Babylon Health, which was one of the first telehealth places in the UK, he showed their kind of computer platform. And they had this thing where they were already transcribing the consultation like we're starting to do now. But if the patient brought up, say, hemoptysis, then what's going to end up happening is that we're going to then click onto a health pathway, but B, maybe a set of differentials will just be sitting there. So technology is going to completely transform this, I think. Again, on the Babylon thing, they had AI triage. So they showed us an AI triage of a person with dizziness and how the AI sort of got through to making a diagnosis. So I think that we still will have to think, maybe, but this will be a really different conversation in 10 years.
So, thinking about communicating uncertainty to our patients now, how can tools help us? I'm thinking particularly around using something like ideas, concerns, expectations, and feelings when we're uncertain.
Oh, we absolutely have to do that. If you miss out what we call ICEF, which is the patient's ideas, concerns, expectations, and feelings, if you miss that out, the consultation is going to go badly because you've got to bring the person with you. So the question you're asking yourself is, why is the patient bringing this symptom to me? And we assume that they've come for biomedical diagnosis and treatment, but it's a little bit more complicated than that. So sometimes the patient might not be worried about their symptom at all and they just need a medical certificate. And they would never have come to the doctor if they didn't need a medical certificate. You might have someone with a brown spot on their arm and all they want to know is it isn't skin cancer, but the next person with the same brown spot wants it removed because it's ugly and they don't care what it is. So I think commonly people are not sure if they need to be worried about the symptom and they want us to tell them how worried to be and whether to be worried. But equally, you could have someone who's super worried and you're not at all worried. And they want you to investigate it and they want you to do something, but you're not even thinking it's a problem. So what happens, and the other thing that happens, of course, is that people get ideas from Googling. They might have even Googled the differential diagnosis of one red eye. And they might be going, this doctor doesn't know what they're doing because they haven't asked me the right questions. You need to know what other people think that they've talked to. They may have talked to people with the same symptom. You always need to know if they've been to another health practitioner and what that health practitioner said. Because if you end up in a position of uncertainty, then there's more than one plan that'll be okay. And if you say something that's really different to what the doctor last week said, then you really confuse the patient and they don't know who to trust. And it doesn't actually necessarily matter that you've said different things, but it matters to the patient. So the thing about the ICEF questions is when you get to the end of the consultation, you have to refer back to their ideas, concerns and expectations. And it alters the whole way that you go about your examination and the way that you go about communicating the uncertainty. But in the end, the patient needs their questions answered. And if you don't know what the questions are, then it's going to be a pretty unsatisfactory consultation.
Thank you, Lucy. So, thinking about reassuring our patients while still normalising diagnostic uncertainty, what are your tips and tricks for doing this?
I think you just normalise that. You can even say patients, look, a lot of the time we can't make a diagnosis because we're seeing people early. And patients know that. Patients know that some things get better. They know that sometimes doctors don't know. But I think what's important is that you conveying that you're comfortable with uncertainty. And if you're really anxious, it's really hard to do that because you've got to be kind of solid and calm and steady. I think that you can say to the patient that, it might be too soon for us to work out what the diagnosis is. We might have to use time to see what happens. The most likely thing is it might go away, but with time it might be clearer what it is. You could do low-level investigation, and sometimes we do that. We might just go, let's just do a blood count and CRP and just make sure they're not really sick and I haven't missed something. It depends a little bit on how invested the patient is in that too. Sometimes we do a low-level treatment. We're all guilty of giving a steroid ointment without actually being quite sure what the rash is. And you could say, well, that's sort of testing out diagnosis too, because if it got better, then all good. You can say to people, look, it's really hard not to have a diagnosis, and that creates anxiety in people. But in some ways, it's also good because if you've got numb patches moving around your body and I give you a neurological diagnosis, it's probably not going to be good news. So actually not having a diagnosis can be good too. I think there's this really interesting thing that happens where we often have a gut feeling that we're not going to be able to diagnose something. So the numb patches that are moving, most of us are going, I think it's pretty unlikely that's going to reach a diagnostic criteria in a biomedical framework. Like I would say maybe most of us would think, maybe 80% chance of that. But what we tend to do is we tend to focus on the 10 or 20% chance that it might be something bad that we don't know about. And when we do that in a consultation, we tell a nocebo story, which is a story that is about a bad outcome that potentially then creates that outcome happening. So, for example, we might say, look, I'm not really sure what's causing your move in numb patches, but it's a little bit odd and I think we should get a specialist to look at it and they might want to do a scan and I think we should do that. And what that does is it creates the sense that this could be something bad. And then the patient goes away and becomes very fixated on the symptom, and in the public health service, it might take 18 months for that patient to see a neurologist and get a negative scan, and by that time, we've got a problem with the symptom. Whereas if we tell a placebo story where we go, do you know what? I am probably about 80 or 90% sure that we're not going to find anything nasty here. That's my feeling about it. I am going to refer you to a neurologist, but I think these symptoms possibly could be gone by the time you get there. That's a really different story about exactly the same thing, and that then helps create a more positive sort of outcome where the patient's not fixated on the symptoms. The other thing I think about uncertainty is that you've got to back yourself. And if you've done a really good differential diagnosis, I think you can back yourself. If you've done a poor differential diagnosis and you haven't thought it through, then you shouldn't back yourself because you might well miss something. So there's a really complicated communication at the end where you're trying to confidently normalise diagnostic uncertainty and be comfortable in it and be reassuring and offer the best possible outcome as the most likely, but you're also covering your butt in safety netting in case you've got it wrong. So essentially, it's quite a tricky transaction at the end to have reassurance and confidence, but also bring in the idea that you could be wrong.
You've brought up some really interesting points there, Lucy. So I wonder if I can pick up on a couple of things. So often we do order extra tests and often they are unnecessary. And often there is an expectation from our patients that they need extra tests. So how can we rationalise ordering a test? What do you think of? Do you think about the positive predictive value, the sensitivity and specificity of the test? What is it that you think about as you order more tests?
I think it depends who's driving the test. So sometimes the patient's driving the test. and wanting testing. And that's a sort of negotiation with them. Sometimes the problem with when we're in an uncertain situation, it's hard to know what the positive predictive value is because we're just fishing around in the dark. And I think most of the time we're either doing the test to reassure the patient we've done something and we maybe need to challenge ourselves on that, or we're going, how sick is this person? Maybe I'll just do a few things just to make sure that they aren't actually sick and I've missed it. So whatever you do, you want to be clear why you're doing it and then challenge yourself if your reason for doing it is a bit flaky, I think.
Yeah, absolutely. And then picking up on your comment about safety netting. So the safety netting for a simple UTI in a sexually active young woman is quite different if you're thinking that she may have a malignancy. So how do you safety net without creating an unnecessary alarm in your patient?
It depends a little bit how worried you are. So what you want to do is convey the amount of worry that you have. And so sometimes we're thinking that someone's chest pain is fine, but the implications of getting that wrong are quite high. And so then we do want to convey the worry quite strongly. But sometimes you've got a patient who we don't really want them to worry, but we do want them to come back if this particular thing happens. The thing about safety netting is, I think I may have actually already said this, is that if you just do a general safety net, that is not really a safety net. It has to be specific, and it's specific for the differentials that you're thinking of. It was Roger Neighbour who created the idea of the safety net, and he said you're to tell the patient what to look for, how to seek help, and what the time course is. So for the urine infection, well, the thing is, if you haven't thought about primary genital herpes right at the beginning as one of your differentials for dysuria, then you're not going to safety net it. And so that's the problem, is you've got to bring up those differentials early on and not just go to this is the most likely in this person. And the thing about the time course is really interesting because there's this really funny thing that happens when you're a novice, and you see registrars do this, is they often put the time course, when they're uncertain about what's going on and they're a bit baffled, they often make the time frame for coming back quite long. So I'll be sitting there watching, they'll say, oh, you come back in 3 weeks if your bowels aren't better. And I'm going, come back in 3 weeks? Right, you'll be coming back in 2 days. So, and I think that part of that is that when you feel uncertain and you're anxious about it, you don't actually want the patient to come back because you don't want to be back in this situation where you don't know what's going on. And so you have to be really careful that that's not driving your safety netting.
Mm. Picking up on that, Lucy, often we do have uncertainty in our consultations. And, you've discussed being a senior when you've got a registrar, but often we're in a silo and we're by ourselves. So how do we cope with that uncertainty? Is a mentor important? Who do we go to? Who do we talk to when there is this uncertainty that just won't leave us?
I mean, we all have that situation. I mean, I think if you can't put something down at the end of the day or the end of the consultation, you're concerned about it, then I think you listen to that. Because a lot of managing uncertainty is about experience and intuition. And intuition isn't a sort of magic thing. It's a sort of accumulation of all of the knowledge and experience and things that we've seen sort of merging together. And so I always listen to that. And again, as a rural GP, I've seen people at midnight and reassured them, examined them, reassured them, said, I think we're okay. And then I go home and get into bed and I can't sleep. And I just ring them up and go, sorry, you have to drive 3 hours to the meeting. I'm not happy. So there's that, getting help. So it's interesting when you ask a colleague, quite frequently what happens when there's diagnostic uncertainty is that they don't know either. And that's quite reassuring, but maybe they say something that you hadn't thought of, and maybe they help you come up with a plan. I think you have to be careful if you're the one coming into the room who's been called in, that you don't undermine what's already been said. And the other problem with asking for help is that, secondary care might not see them. And so then you've got another problem. The other thing I think is that before you ask, it's really good to try and work it out yourself. So give yourself a diagnostic pause, slow down, get the patient out of the room, whatever you need to do, and just see if you can work it out, because working things out is part of sort of learning. I mean, I do think there's a problem, and especially in the culture of medicine, about asking someone else where we feel like we're going to be put down. And it's really important that we create a culture in our workplaces where we ask each other questions and where we have opportunities to actually talk to each other. Because one of the problems in primary healthcare is you're alone in a room all day, and you can go all day and not see another doctor and not see another health practitioner to ask. So yes, asking is really important.
So, Lucy, I wonder, when you are faced with uncertainty, do you have any little tools that you can advise us on? There's one that you use called DRATS. Tell us about that.
Well, originally it was called RATS, and I've called it DRATS because D stands for differential diagnosis. You've got to do a differential diagnosis if you can. And R is red flags. So what are the things that I don't want to miss today? And then A is asking the patient, and that's to do with the sort of ICE questions. T is for tests, but that actually includes the test of time, which is one of the most powerful tests in uncertainty, is just giving it time to see what happens. And S is for safety net. There's another beautiful one that Sean Hanna told me, and again, I couldn't find the reference for this, which is called MICO, and that's masterful inactivity with cat-like observation.
I love Marco. That's priceless. Thank you so much. To conclude our podcast today, Lucy, some take-home tips for our listeners, please.
Well, the first one is it's always too soon to panic, so you've got to manage your panic. You don't need to know, but you do need to make a plan, and you do need to safety net. And if you've got a differential diagnosis and you go through diagnostic reasoning, that actually is what allows you to back yourself so that you can communicate uncertainty with confidence.
Thank you, Lucy. It's been a pleasure talking to you today. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll find a list of resources used in this podcast at our website, goodfellowunit.org. To get in touch, please email podcast@goodfellowunit.org. Thanks for listening.